Good evening, everyone, and welcome to the Domestic and Family Violence Information Sharing Schemes webinar. My name is Dr. Bianca Forrester, Clinical Advisor for Workforce Development at West Vic PHN, and I'll be your facilitator for this evening's event. Alongside me is Jade from Workforce Development, an officer at the West Vic PHN. So the purpose of tonight's webinar is to bring you up to date with the change legislation in regards to family information sharing in the state of Victoria as it relates to child wellbeing and family violence. So this evening's webinar is part of a broader suite of workforce development initiatives to bring primary care along with these changes and best practice care in recognising and responding to family violence in our communities. So I'd like to begin by acknowledging the traditional owners and custodians of the lands and waterways from which we're all zooming from this evening. We recognise their diversity, resilience and the ongoing place that First Nations people hold in our communities. We pay our respects to elders both past and present, and we commit to working together in the spirit of mutual understanding, respect and reconciliation. We support self-determination for First Nations people and organisations, and we'll work together on closing the gap. Now, the majority of our webinar events are recorded and freely available on our PHN Learn YouTube channel, and Jade will put the link to access our recorded webinar events in the chat. Our upcoming events are on the screen this evening. I'd like to make a special note that the Domestic and Family Violence Echo Network is resuming next Tuesday, the 17th of May. These lunchtime sessions will run for 4 weeks, and it's not too late to register. So Jane will put the link to our upcoming events into the chat, where you can find out more and register for these sessions. So it is with great pleasure that we announce our annual Primary Care Refresher Conference, and this is open for registrations. The conference is open to all primary care clinicians. There'll be GP stream and a primary care stream, and these will be running concurrently. The program has been uploaded into the handout section, and so if you'd like to review the program, it's being run as a 2-day event, both online and hybrid format. So while you have the opportunity to register and come virtually to the event, it also is face-to-face at venues in Geelong, Ballarat, Horsham and Warrnambool on the Saturday. Now, please know that face-to-face places are strictly limited, so we'd recommend registering ASAP, because if you'd like to have that chance to network with your colleagues face-to-face, so get it online and register. So the Health Pathways is a resource that I just wanted to promote this morning, and the Health Pathways relating to this topic is on screen at the moment. So it now brings pleasure to introduce Dr. Jennifer O'Neill. She's a GP and academic at the Department of General Practice at Monash University and a researcher with the Safer Families team at the Department of Uni Melbourne. In a moment, I'll hand over to Jenny and I'll ask you to also introduce yourself. But I'd also like to introduce Ms. Vida Louis-Mate, who's a family violence advisor for Barwon Health, Geelong University Hospital in our region. So to provide some of that really great grounded and localised resources, Vida joins us this evening. So thank you to our speakers for this evening. As I mentioned, please do put any questions in the chat. In fact, what I might do, Jennifer, is I might throw to Vida first, introduce yourself, and then back to you, and then you can take it away. Great, thanks. Vida, if you don't mind taking a moment to introduce yourself to our participants this evening.
Sure. Hi, I'm hoping, can you hear me?
Yes, we can. Yep.
Great. So I'm Vida Louis-Mate, social work trained. I've worked for Barwon Mental Health Drug and Alcohol Service now for 2 years. And a lot of that role has been assisting the service to implement the Family Violence Information Sharing Scheme and Child Information Sharing Scheme in partnership with Over the Road and the main hospital. Prior to that, I've worked 22 years as a social worker in a myriad of roles, both direct service with women and children experiencing family violence, and I've also done a lot of education around this topic over the years. And thanks for having me.
Thanks, Vida. And if anyone's interested in coming along to Project Echo, Vida has been such a valuable panellist. So you'll be seeing more of Vida as Project Echo if you register. All right. And Jenny, Jennifer's also going to be a Project Echo presenter, but thank you for coming tonight to really provide that extensive background on the legislative changes. Over to you, Jennifer.
Yeah, no worries at all. So I'm Jennifer Neal. I'm the Curriculum and Assessment Lead at Monash University General Practice, Department of General Practice. I've been training GPs and other health professionals in family violence for many years now. I do a lot of work for Safer Families and also for the Harmony study through La Trobe University. I've co-authored 2 of the chapters in the RACGP Guideline on Abuse and Violence, the White Book, and also authored a Marim supplement to that White Book as well. So a lot of my work has been with the Readiness Program through Safer Families. This is headed up by Kelsey Hegarty at the University of Melbourne. And the aim of this is to make primary care ready to address domestic and family violence. Tonight, we're going to focus on the information sharing schemes in primary care. This is a very Victoria-specific topic, and I'll get onto that in just a moment. But before I do, I'll just briefly run through what we're going to go over tonight. So we're going to describe the information sharing schemes. We're going to talk about the family violence information sharing scheme and the child information sharing scheme. And we're going to explain how they relate to general practice and other primary care practitioners. We're going to talk about some resources for implementation and also just give some case-based learning. So talk about a couple of cases that might relate to information sharing as well. I just want to acknowledge the survivors in the room. Given how common family violence is, it's very likely that when a group of people gathers, there will be at least someone that has been in some way affected by family violence in their own lives, whether it be that they're a survivor themselves or whether this has happened when they were a child and was related to their parents. I know that this can be a really difficult topic, and I just want to acknowledge the strength and resilience of those that are survivors. And I just want to say that if you do find this topic difficult in any way, to contact your GP, a trusted friend or family member, or also the 1-800-RESPECT number as well. So why do we have this scheme in the first place? So essentially, back in 2014, a lot of you will probably remember what actually happened to Luke Batty. You probably know of Rosie Batty. You would have heard of her as being the Australian of the Year back in, I think it was 2016 or 15 or something. But what actually happened was she was at the cricket. Her son was playing just local cricket on a cricket pitch in 2014. And Luke's dad, there was actually an intervention order out against him, but one arm of the police was not talking to the other arm of the police. And he really should have been in jail. If they'd been talking together, they would have realised that he should have been in jail, but he wasn't. And so he was actually free to kill Luke, just like this headline of the newspaper says. And Luke was actually killed by his father in absolute tragedy. Now, what happened after this in 2015, very shortly afterwards, there was a Royal Commission into family violence. And this was really because of what actually happened to Luke. I mean, there were many other cases as well, but the case of Luke Batty really spurred on the government to make changes. And what actually happened out of this was what we call Marim, which is the Family Violence Multi-Agency Risk Assessment and Management Framework. So the point of Marim was to ensure that services were effectively identifying, assessing and managing family violence risk. So it was established under law, and the Marim framework provides guidance to organisations such as family violence organisations. Now, primary care is not actually under the Marim framework, but what happened alongside the Marim framework was the information sharing schemes, which do directly affect general practice. So the pillars of Marim, there are 4 pillars: to have a shared understanding of family violence, to participate in consistent and collaborative practice, including risk assessments. So now family violence workers do a standardised risk assessment of family violence survivors, which is under Marim. They understand their level of responsibilities for risk assessment and management and undertake systems, outcomes and continuous improvements at an organisational level. But more specifically to general practice and primary care is the information sharing schemes. So there are 2 information sharing schemes. There is the Family Violence Information Sharing Scheme and there is the Child Information Sharing Scheme. Now they're very similar, but there are some differences between the 2, and it's important to understand that. Now, basically, the reason that they relate to the reason that they relate to general practice is that we are actually what is called information sharing entities under these schemes. So only prescribed information sharing entities can share information under the Family Violence Information Sharing Scheme and the Child Information Sharing Scheme. But general practitioners, not all doctors, but general practitioners and primary care nurses are in fact information sharing entities under this scheme. So general practitioners and practice nurses, some of the other, look, there are many others, but I've mentioned some of the other ones here that might seem relevant to primary care. Police, Magistrates Court of Victoria, Children's Court, public hospitals, maternal child health nurses, mental health services, specialist family violence organisations, child protection, sexual assault services, homelessness services, schools, kindergartens, daycare centres. These are all information sharing entities under these information sharing schemes. So there are a few others that are also called risk assessment entities. So they're slightly different than information sharing entities. They are actually information sharing entities, but they actually have slightly increased information sharing powers compared to standard information sharing entities. And these are child protection, specialist family violence services, and child first services. So risk assessment entities can request information for family violence assessments, whereas ISEs, information sharing entities, can only request information for family violence protection purposes. Now that might sound really similar to you, but they are actually two different things. Specialist family violence services can actually request information when they're doing an assessment. But for general practitioners, if they want to request information, it needs to be for family violence protection purposes. So it all comes down to risk and risk assessments and understanding the risk assessment of the patient that you have in front of you. We'll talk a little bit about risk assessment in a moment. So what information can actually be shared? So information must be for family violence and risk assessment and management purposes. So you cannot share the fact that a patient, had some completely unrelated medical illness that was not in any way related to family violence and risk assessment and management purposes. You can only share information that specifically relates to risk assessment and management of family violence. The information might include information on perpetrator behaviour, and it might include information promoting a child's wellbeing or safety. And we'll talk a little bit how those scenarios are a little bit different in terms of the requirement for consent. So to be able to do this, we need to understand the level of risk that the survivor we have in front of us actually has. And to do this, we need to do what's called a risk assessment. So when we do a risk assessment, we're going to take into account three things. First of all, and probably most importantly, is the victim survivor's self-assessment. So the victim survivor is an expert in her own safety. And I use the word her because in general, this is a gendered issue. It is, however, possible that a survivor might be a male, but in vast majority of cases, survivors will be female or children. So the victim survivor's self-assessment of her own safety, this is her lived experience. She's been living this for, who knows, months, maybe even years. She has a very good idea as to whether she is currently safe or not. So this is the first and probably the most important thing to take into account. And so to ask about that, we're going to say to her, do you feel safe to go home tonight? Do you feel safe at home? Is your partner capable of causing you serious injuries or harm? Is your partner capable of even killing you? These are really important questions to ask when you're assessing her perception of her own safety. Next, we take into evidence-based risk factors, and there are many evidence-based risk factors, but I'm going to show you a slide in a moment that has a lot of the risk factors that we know of. And as well as that, we're going to then take into any information sharing that has occurred between any agency. So if you've spoken to family violence or family violence services, or if you've spoken to the school about a child, you're going to take those things into account, and you're going to put those three things together to form a professional judgment, and you're going to take into account any intersectionality. For instance, is this family from a group that is discriminated against in general in society? such as Aboriginal or Torres Strait Islander family. These are the evidence-based risk factors that I was talking about. So all of these things are known to increase a woman's risk of dying or being seriously harmed by the perpetrator. But all these things are about perpetrator behaviour. So they're not about her behaviour, they're about the perpetrator and his behaviour. We know that if a woman has been strangled or choked, she is at 7 times increased risk of dying. If there has been a threat to kill the victim, there is a 15 times increased risk of dying. We know that when there's an increased severity and frequency of violence, that there is a significant increased risk. We also know that the riskiest time for a woman who is being subjected to family violence is when she's planning to leave or a recent separation. So within the first 3 months of leaving is one of the riskiest times. And you get a lot of people saying, well, why don't women just leave? There are so many reasons that they don't leave, but one of them is that many of them actually know that the violence might actually increase initially rather than decrease when she actually is going to leave. Controlling behaviours. So you've probably heard the term coercive control. So coercive control is when basically the perpetrator wants to control everything about the victim survivor and not allow her to do anything that she would like to do. For instance, she might be prevented from actually spending time with any of her friends or family members. He might track her, track where she goes. She might not be able to actually go out to the shops without him tracking her on Find My iPhone, to making sure that she's not going anywhere else or not going to visit any friends or family members, and it tends to very isolate the victim survivor. So use of weapons is a tricky one, because in fact the weapon that's most likely to kill is in fact a man's hands. The second most likely weapon to kill is a knife in Australia, and that's, you know, in every household. So in reality, use, you know, weapons or availability of weapons is a tricky one, because there are weapons available. However, we know that in America, you know, guns are obviously a much bigger problem than they are here. But if, you know, it's important to know whether there are availability of guns or any other weapons. Harm or killing pets or other animals, sexual assault of victim, drug and alcohol abuse. We know that these all can increase risk. These are all about the perpetrator's own behaviour. So when we're asking about the evidence-based risk factors, it's important to note that it's not about the victim survivor and her behaviour. It's actually about, we're finding more, as much information as we can about the perpetrator behaviour. Why is this important? Because when we are actually sharing information, it may be that we actually need to share information about the perpetrator and his behaviour, rather than just share information about the victim survivor. So what we're going to do is, under the Family Violence Information Sharing Scheme, we will share the level of risk that we are dealing with this particular victim survivor. Is she at risk? Is she at elevated risk? Is there a serious risk or a serious risk that requires immediate protection? At risk, there may be no high risk factors present. She may have supports in place. The survivor may self-assess her risk level as low. If there's an elevated risk, there may be a number of risk factors present, including some high risk, but professional judgment deems that a serious outcome is not very high, and survivor deems her risk as moderate. Whereas a serious risk, there may be high risk factors present, and there may have been an increase in severity or frequency of violence, and survivor assesses safety as low and fear level as high. Serious risk and requires immediate protection is obviously of great concern, and one of the reasons we need to know about this is because in fact this does change the consent requirements. So we do actually require consent from a victim survivor to share information, except there's 3 times that we don't. If there is an imminent threat to the survivor and the children, but I would say that even if there's an imminent threat to the survivor and the children, she needs to know if you are going to be sharing information, because she has to keep herself safe. So if she knows that information is going to be shared and it might actually end up being shared with the police, she needs to know what's going on. Okay, because it could actually potentially alert the perpetrator as to what's going on. That doesn't mean that you may, the ideal situation is to share with consent. And so if you've got a woman who's at imminent risk, the idea would be to be sharing with consent is the absolute ideal. But if she says, no, I really don't want you to share, and you think, oh goodness, I'm really thinking that she's at imminent risk here. I think that she's going to, could be seriously harmed when she goes home. You need to say to her, look, I'm really concerned that there is a serious risk here, that there is an imminent risk. And I really think I am going to have to alert a family violence worker and or the police of what is going on. And let her know that what you're thinking of actually doing, so that she can keep herself safe the best that she can. I think that's an ideal time to be involving a family violence worker rather than it just being on you, the general practitioner, because family violence workers are really expert in dealing with risk and doing risk assessments. And I think that would be a really important time to be referring to a family violence worker. So if they are a child, you also do not necessarily need consent. Again, look, if possible, if it's, for instance, if you've got a teenager, you might want to have a chat to them about the fact that this is something that you might be sharing, and we'll talk about some instances of how you might be sharing information a little bit later on. But for instance, if you've got a young child and it hasn't got to the threshold of a mandatory report, and in Victoria, our threshold is for mandatory reporting, that we must hold a reasonable belief that a child is at risk of physical or sexual harm. Now, you might think to yourself, oh, look, I don't have a reasonable belief that they're at risk of physical or sexual harm, but I just feel like there's maybe something going on here that just doesn't add up, and I'm just a little bit concerned for this child. This is where you can actually share information with other entities. So whether it be the maternal child health nurse or a school or family violence workers if they're involved with the family, a vulnerable children's organisation, you might want to even make a referral to a vulnerable children's organisation. And it may well be that the information you gather actually causes you to realise that they do meet the threshold for a mandatory report. It's really, as a child, you do not actually need consent to share information about a child with other information sharing entities, but it does have to be for family violence protection purposes. It can't be for another purpose. Sharing information about the perpetrator, provided the information is directly relevant to family violence. So we can actually share information about a perpetrator. So if, for instance, if you're a GP and you get a phone call from a family violence organisation saying, I believe that you're the GP of Mr. Joe Bloggs, we would like to know a bit more about his current behaviour, because it directly affects the risk assessment of the survivor that we actually have with us. That's really important information about perpetrator behaviour that could actually make a really big difference to the risk assessment and safety planning for a family violence survivor. You do not actually require consent from, in fact, you really definitely should not let that perpetrator know that you've actually been contacted at all. And you do not need consent from the perpetrator to provide that information to the information sharing entity or risk assessment entity that's actually talking to you. So when you get a request, so as a GP, there's kind of two main scenarios in terms of this scheme. One is that we'll get requests for information from other organisations. And the second is that we may actually decide that we would like to contact another organisation to get information from them. I think probably at the outset, the most likely scenario is that we will be asked for information from another information sharing scheme, information sharing entity or risk assessment entity. So what we need to be able to do is have protocols and policies in place in our clinics so that we know what to do when this happens, so that when it does happen, because it will happen at some point, we're not you know, scrambling trying to work out what actually to do. So we may even do something like have a pro forma or a particular form that needs to be filled out by the organisation. That would be the ideal, would be for a practice to actually have some sort of form to then ask the information sharing entity to fill out. And what they're going to say is who they are, you know, are they, you know, verify that they are an information sharing entity. And don't just take the phone call and assume that they're an information entity. You know, say to them, I need to verify who you are. Go to their website, call the number that's on their website and actually speak to them directly through that number, so that you absolutely know that the person that you're talking to is the person that you're talking to, because this is, you know, we're sharing, you know, potentially confidential information about perpetrators, children and survivors. And so it's vital that we can verify who the information is coming from. So we're going to verify who it's from. We're going to hopefully have a clinic process in place. That may well be that it goes to the practice manager. They then give a form to the person who's wanting the information, so that on the form you might have some things like saying which information sharing entity they are, their contact details, what the purpose of this is. You know, it needs to obviously be for family violence risk assessment and management purposes, or if it's from an RAE, for assessment purposes. And the current level of risk of the survivor, and that information then, you know, would go to the GP, and the GP will then contact the information sharing entity. So the consent, though, from the survivor can be either in writing or verbal. It doesn't have to be in writing. So we, you know, if consent is required, obviously from our victim survivor. Document everything carefully, and I'm going to talk a little bit about documentation a bit later on, so I'll get to that in just a moment. So when you then get this request, you need to decide whether you're going to share and what you're going to share. So first of all, is it from an ISE? And yes, if it is, then is there a reasonable belief that the information is for family violence protection purposes? And hopefully, because you filled in the form that you've prepared as a practice, you know that it is in fact for family violence protection purposes. Is the information excluded? So is it information that you know that could endanger person's life or contravene a court order or law? So if it's not, then is it relating to a perpetrator or a child? So you do not then need consent. Or if it's obviously for a survivor, you will need consent from the survivor, unless it's an imminent risk, which is the next point here. Is there a serious threat to life, health or safety? Then consent is not required to share information, and then all other cases will require consent from the victim survivor. So the other scenario in general practice is requesting information. So we can actually request information if it's for protection purposes or for child wellbeing and safety purposes under the Child Information Scheme. And again, the requests can be made verbally or in writing. And here are just some of the information that we suggest that you actually put there when you're making a request. So you'll say who you are and what your title and occupation is, what level of risk this survivor or child you're dealing with, what the purpose of the request is. In other words, is it for protection purposes under the Family Violence Information Sharing Scheme, or is it for child wellbeing and safety purposes under the Child Information Sharing Scheme? Identifying details of the subject of the request and whether this person is a survivor, child or perpetrator that you're actually seeking information about. And so GPs might make that request of a family violence service, or they might be making that request to a school or to a maternal child health nurse. So, you know, to add, like I said, with the child wellbeing and safety purposes under the Child Information Sharing Scheme, it may be because you're thinking, well, I'm not quite at the threshold for mandatory reporting, but I'm just concerned that I don't have the full picture here. So I need a bit more information to have a full picture about how to keep this child safe and ensure that this child is actually safe. So in putting this all together, there is a bit of information out there that you can actually get. It's not actually easy to get all that much information. The government, I think I've got it there. The second point there, which is the Family Violence Information Sharing Guidelines. The government actually on their Marim site has information about how to implement the information sharing. There's some great information by Safer Families. So you can actually look at the information sharing in Marim under Safer Families, and Safer Families actually have a whole e-module relating to information sharing schemes in Marim in their Readiness e-learn modules. I'd really encourage you to have a look at the e-modules, but not just the information sharing one, but the e-modules that are also specific to family violence as well, because I think they're a really great learning tool. So I'm just going to go on and just present a couple of case studies of how, specific to general practice, how we might actually use these information sharing schemes. Now, these case studies are not actually based on real patients, and there's a good reason for that because of confidentiality, but they take facets of various different patients. A 4-year-old has presented to the GP with a broken arm after a fall at home, and Dad has brought him in today. Now, the GP is already aware, because the GP actually knows the family, and this is often the case in general practice. The GP is aware that the father is a perpetrator of family violence because he knows that the GP has met the mum on a number of occasions, and they know that there has been coercive control perpetrated towards the mother. As far as the GP knows, there hasn't been any suggestion of involvement of the child, and the GP has asked the survivor, the woman, about this, and she's always denied there being any issues with the children. But the GP hasn't seen the mother for a few months, and there's currently no involvement from Family Violence Services, because when the GP spoke to the mother a few months ago, the mother was not particularly keen to involve Family Violence Services at that time, and the GP respected that that's what the mother's wishes were, and the mother didn't turn up for follow-up. So the GP thought to themselves, look, I know that the father is a perpetrator of family abuse, family violence at home. I don't know whether this is a child protection matter, or is this just a standard buccal fracture of the radius? That's pretty common in this age group. It's probably just a standard buccal fracture of the radius, but could there be something else going on given my knowledge of the family and the fact that there has been violence within the family? So the GP calls, this is after the patient, the child gets the back slab put on and ends up going home. And the GP requests information from the maternal child health nurse because they're aware that the child has recently been for their 4-year-old assessment. And he also contacts the boy's childcare centre just to get some more information to see whether there's anything going on that the GP doesn't know about, just because the GP thought, well, let's put our heads together and just see if there's any pattern here. And consent is not required because this is under the Child Information Sharing Scheme. So the GP asked the maternal child health nurse if there has been any concerns about the child, and they said that they did actually note that there was quite a few bruises on the child 2 months ago, but again, they weren't really sure whether it meant anything or not. The GP also speaks to the childcare centre, who said, well, we actually, a few weeks ago, we noticed that there was bruises on his buttocks and his torso. And the GP thought, oh, that's an unusual pattern of bruises. 4-year-olds get bruises on their legs and shins, but they don't tend to get them on their buttocks and torso unless it's actually there because someone has actually harmed the child and it's caused them to be there. And the GP starts to think, I now hold a reasonable belief that this child is at risk of harm. And it actually helps the GP to be able to formulate the fact that there could be risk here, and that this is something that needs to be reported to child protection on the possibility that in fact this child is being physically harmed by dad. Now, the GP also wants to just discuss it with the mother that this is what's going to be happening so that the mother is aware, because it's going to help the mother increase her safety if she's aware what is going on and what is happening. So the GP does make an effort to have a discussion with the mother about this as well. So it's a slightly different scenario we've got with that case study number 2. The Specialist Family Violence Services calls the GP clinic requesting information regarding the GP's patient called James. So the clinic responds by saying that's fine, but you need to fill in our information sharing request form, which notifies who you are, what the purpose of the information is for, and what level of risk we're dealing with. So the GP phones the Specialist Family Violence Services on the number that's listed in that particular organisation's internet page, so they know exactly who they're talking to, and verifies who it is that they're talking to today. The Family Violence Service is performing a risk assessment on a survivor, James, who has left the perpetrator. There is an intervention order in place, but they are seeking further information about that perpetrator, James, to better understand his behaviour and the risk he currently poses to the survivor. And they're aware that you are the GP of James. Again, in this situation, consent is not required because this is about information regarding a perpetrator, not information regarding a survivor. So in particular, they're seeking information about current drug and alcohol use and his current mental state. But the GP is actually able to share the fact that James has been hanging around the survivor's workplace, because this is information that James has actually shared with the GP, because James was so upset that the victim survivor actually left the relationship and has been trying to get her back again. So the Family Violence Service is able to add this evidence to their risk assessment, increasing the safety of the survivor. And the survivor is able to be informed of the stalking behaviour in order to increase her safety, her own safety. So documentation is really important. We want to document who is the information sharing entity that requested the information, the date that the request was made, if the request was refused, to document why it was refused, and document which sharing scheme that you're giving the information under, whether it's Family Violence Information Sharing Scheme or the Child Information Sharing Scheme, or both, to record how the threshold for sharing was met, what information was disclosed and the date it was disclosed, and relevant risk assessments and safety plans that have been prepared, and a record of consent if required. And of course, if it was written consent, you'd want to have that scanned into the notes. If sharing as a perpetrator, it's actually, really, you've got to be really careful about the information you put in a perpetrator's file, because he may well have access to his own file, because by law you are allowed access to your own file unless there is something that would cause harm to yourself or someone else. So you just need to be really careful what information is put into the perpetrator's file, so that he doesn't actually find out and understand that a victim survivor was going to a family violence worker, or was basically, it could give him information that she's been seeking help from a family violence worker, and could put her at risk if he was to understand that it was written in this file. So just to finish up, the Readiness Program. This is a program of modules. First of all, there's E modules, and the information sharing scheme is one of those E modules. But there is also a program that the Safer Families has actually written, whereby your practice can actually have whole of practice training in family violence. It's 2 visits, it's 90 minutes per visit, and it's run by a GP educator in family violence and a family violence worker together. It's really great interactive sessions. The second session even involves role playing with a simulated patient, which is absolutely fabulous way of actually putting what you're learning into action. So if you're interested in those things, please visit that website down below there, so www.saferfamilies.org.au/readiness program, because you will be able to find out about the modules, the e-learning modules, as well as the program, this readiness program as well. So yeah, it's a great program. I've been working with Safer Families on this program for some time. And it's really interesting because, you know, most GPs have actually learned very little about family violence. You know, like most of us in university didn't get any training on family violence. These days, I think the average in Australian university is about 2 to 2.5 hours of family violence training for an entire degree. So, you know, a lot of us can do with some extra training in family violence. It is a health issue. We know it's a health issue because it affects women's health, it affects children's health. So just something to have a think about, whether you'd be interested in learning a bit more about family violence if you haven't done it already. So I'm happy to take any questions now. And Vida, I think you probably have a few things that you'd love to say as well.
I've been just scribing away or making some notes just to prepare for the questions, and just thinking about what we have in place here and to support information sharing.
Yeah, so I wonder, Vida, I guess that's a question I was, you know, interested in, maybe reflecting. You've just been for Barwon Health and Health Services. You've had a couple more years of implementing these changes. You know, I guess I'm keen, Jennifer, to think about, you know, what types of things might we think about in primary practice in terms of implementation. So, you know, some of the things you mentioned was the requests, and there's quite a process involved in those requests, and I wonder if you know, I'm wondering how we might streamline some of that, perhaps wondering whether risk assessments, you know, the entities that are requesting the information, whether they might, you know, is this normally done by a phone call? Do they write to us to help kind of move along some of those processes? What's your experience, Vida?
So we, in partnership with the main hospital, with the health information sharing team, also with freedom of information and legal, came up with a form that, in terms of what Dr. Neil was describing, the form covers a lot of those points, asking if it's what are you seeking information about, who are you seeking it about, under which schemes. It asks about consent, and it asks for the purpose. And what's interesting is most of the requests here, and I think it was in Jan or Feb, we received 100 information sharing requests at Barwon Health, primarily from Barwon Orange Door, and primarily from Men's Family Violence Services. The top snippet of information requested that comes here, one of the top snippets, is GP details. And I think it's very it's relevant for men's family violence practitioners to be asking for GP details frequently, in amongst asking for mental health, AOD, pattern and history, because a lot of people choosing to use family violence where police attend an incident, referrals go to Orange Door. A lot of perpetrators or people using family violence are not contactable by specialist services. But GPs or health services are services that most folk in the community are likely to have a touch point with or go to at some point. So it's interesting, I was just reflecting as Dr. Neil was talking that, yeah, GPs are often one of the top pieces of information requested, and I think that's the rationale as to why. So our process is, we have a particular process where they all go through FOI. We have freedom of information at the main hospital. We've got a dedicated email address that's sent out to key stakeholders and partners. But in saying that, information can be shared in a myriad of ways. Information can be obviously shared formally with a form, can be shared in professionals meetings, and I've had GPs sit in professionals meetings, case plan meetings with mental health, family violence services. Obviously establishing, as Dr. Neal's talked about, the identity of the requestor, that they're legitimate, they're under the schemes. So yeah, or where we're co-working, where a GP might be speaking to someone and a family violence service is involved, that communication can be via email and in other ways. So I think it's thinking about how formalised or how informal we may be at times where the risk is critical and it's potentially lethal. So one example came to mind: a guy blew himself up with a gas cylinder. His partner was in the home, and so I had Orange Door quickly ringing to find out where he was. Was he in the hospital? Could I quickly find out or assist to find out where he was, so that immediate safety planning can occur with victim, survivor, and children. That was Friday at 4:30 in the Arvo. So in that case, I already knew the person I was talking to, just gave the info over the phone, and then, yeah, documented. The documentation is a big deal as well in mental health services, whereas we know people can go under the Mental Health Act. And so there's a risk that if people are under the Mental Health Act in an inpatient acute psychiatric setting, they can get access to their whole file. And obviously that can pose real risks of harm and escalation if the person using violence might be the carer and they're sitting there reading their partner's details and can see FVISS requests. So we have particular language around that, around how we document and store these requests.
Okay, thank you. And I'm just thinking as well then that urgency, I guess, in that case that you described is really an important factor. But if, but Jennifer, you described before, you know, that practices may create templates and tools to kind of facilitate the process. You know, is there something that's being shared for clinics to be able to implement?
It would be good. I'm not aware of there being any particular things out there yet. So I think some individual practices have probably started the ball rolling and have done their own, but I'm not aware of any resource as yet for general practice. I don't know, Vida, if you're aware of any particular general practice ones, but
no, I know I'm not aware of any specific general practice ones.
But it would be a good idea for someone to develop it and to actually, you know, share it with other general practices, because I can't see any reason why there wouldn't be a fairly standardized thing, a standardized form. It's not even that many things that need to be on the form, really.
Yeah.
So I think that would make a lot of sense to do that.
Okay, thank you. I was just thinking about the example that you described, the case you described of the 4-year-old, and please do ask questions to our participants. If you've got questions, please do put them through the question and answer. So I'm happy to ask a few while I'm just thinking about the case of the 4-year-old where the GP was forming the reasonable belief. In a sense, I guess I was thinking about where do we draw the line between that GP forming reasonable belief and someone creating a risk assessment. So I guess, Jennifer, I just wanted to think about where as GPs we think our role sits around, say, potentially what the GP was doing by requesting information from other providers. You know, is that something that we'd expect GPs to be doing, or is that potentially if they had some concerns?
I think it comes down to I mean, I think we have an obligation if we're starting to think that maybe there could be something going on to try and keep a child safe. So I mean, I don't think the GP had to do that, but I think it was good that the GP did that.
Yeah.
And you know, I think it's really best practice is, I mean, to keep a child safe. And just because the child doesn't reach the threshold for reporting doesn't mean they're not at risk in some way. The threshold is actually quite high, really. It doesn't even, you know, encompass things like psychological abuse or anything like that. In Victoria, we have to have a reasonable belief that the child is at risk of physical or sexual harm. So I think, you know, if you've got a gut feeling that there's maybe something not quite right, I think follow your gut.
If the GP had the same level of information, they knew that the young person was injured, came in with the father, yeah, as you said, hadn't seen mum for a while, but knew that there was coercive control, could they, through the child information sharing scheme, share that information with an entity that might be another way? Would that also be some way they could use the information sharing
Yeah,
scheme?
sure, absolutely. A vulnerable children's organisation would probably be the ideal entity in that situation, I would have thought, yeah.
And I'm just thinking, who would that be for our region? I know, Vita, you're in Bowen Health, but if we're thinking kind of broadly out west, when we describe vulnerable children's organisation, might that be somewhere like Orange Door? Or?
Yeah, traditionally it was Child First, but I think Orange Door now encompasses a lot of what they do. So I would have thought it's probably Orange Door.
Yeah, that would be my understanding, that what was formerly Child First are now called Child and Family Teams, located within Orange Door Services. Where there's not currently an Orange Door, as I understand, then it would be still Child First. But yeah, otherwise probably be the local Orange Door, which has other services working with Aboriginal people, and there's other services co-located there as well.
So Orange Door, I think, is a good link for us in the Geelong and Ballarat region to be familiar with. And in my experience, Jennifer, I'm not sure about yourself, but you know, in the past where it was difficult when we did feel the sense of it being grey and it wasn't clearly meeting that threshold for us to call child protection. Yeah. You know, at times we would be thinking, oh, wouldn't it be good to be able to speak to someone for some information or advice? And we used to call that informal sharing. And I know that child protection often can't offer us that, but I think in this time, where, like you say, where you do have that gut response and you think, what else could I do? I mean, in this case, the GP made some great initiatives, but for someone who's just a bit unsure and wouldn't mind a little bit more information and advice, now it's okay, isn't it, under this child information sharing to call those organisations?
Yep, I absolutely. I think that would be very reasonable. Yep.
And so in this case where it might be just calling for advice or calling and saying, I actually want to share this information because I think it'd be good if this was documented. Yep. And then because it's a child, they wouldn't need consent to share that info.
That's
but
right.
we hold the other the survivor in mind, and maybe picking up the phone and calling and raising those concerns and seeing that everything's okay.
Yeah, I think the right thing to do is to notify the survivor of what's going on so that she in amongst it all can keep herself safe. Yeah.
Okay. I guess it's kind of, so it's interesting, isn't it? There's a few there's a few options I think that this scheme opens up that we perhaps didn't have before. Would you agree?
Oh, absolutely. Absolutely. I think there's, I mean, to be honest, GPs aren't going to be doing it all the time. It's not, it's not like you're suddenly going to get a flood of 10 requests in a week or anything. But I think it will happen more and more as organizations share information. But I think particularly when it comes to children, I think it's there's things like this that would have kept Luke Batty safe. They're having different organisations speak to other organisations, and I just hope that it means that we're going to have a lot less Luke Battys, and I think that there's a lot of scope for it to cause real benefit for survivors.
Absolutely, yeah, absolutely. I thought it was interesting, again, when we were talking about really you re-emphasise, and I think it's worth kind of underlining that in the ideal situation, we do want the survivor to be aware of and consent, ideally, to their information being shared. Do you have either of you have any tips, I guess, for practice? Because, I know that by the time a survivor comes forward and talks to the GP, they may have often been seeing that GP for, some period of time. Any tips for how we can kind of, help a survivor feel, I guess, that this is a safe process for them?
Yeah, you go, Vita.
Yeah, I suppose one simple sort of way of framing the purpose or rationale for why I might ask a complete stranger, not out in the street, but working in services where I've had to follow up and cold call people where there's been police reports, might frame it around, you know, my duty of care to your health, well-being and safety is to check in or to ask you about XYZ that probably has an impact on trauma, physical health, mental health, and almost give a bit of a preamble or rationale as to why you might be asking some of these questions. I think the issue of, I think gaining consent and transparency is absolutely best practice. I suppose there's been a few instances, I was thinking of a case example, and I'm aware of the time now of where I have suggested to a clinician to go to the GP and divulge that she's actually, she was seeing in good faith a perpetrator and a survivor who are on a high risk panel where there's risk of homicide. And my guess is that that GP had no idea. And there's drugs and alcohol, and there's a whole range of intersecting complexities, and they're homeless. So I think it's just thinking about then what are the risks of the victim survivor telling the partner, if they're still with the person and really fearful that, oh, my GP actually asked me or told me. I think we just really need to think about that. I agree consent is best practice, but just need to think about, are there any dangers of her disclosing to the partner, person using violence or another relationship? Yeah, so for me, it's probably on a bit of a case-by-case basis, depending on the risk level and depending on the relationship as well.
Yeah, thanks. And you, Jenny, any tips for?
Look, I haven't come across the scenario yet, but I can imagine that there would be some women that would actually feel very concerned about the idea that information could be shared. And I think that we need to let them understand that the threshold is really high for doing it without consent, so that they understand that really the only time that we would be sharing their information without their consent is if we actually honestly thought that they were, you know, at risk of dying right now, today, sort of thing. So I think if they understand clearly what the threshold is, and we don't just say, oh yeah, we can share information, I think that would sort of help as well.
And I guess it's us being clear in ourselves of who, and explaining to them who we would be sharing that information with.
Yes.
Yeah.
And that it essentially it's for her safety. It's about risk. It's about safety. Yeah.
Yeah. Whether or not there's also a transparent conversation about the type of information that's shared. What is considered family violence risk relevant? What is considered risk relevant when we're talking about child wellbeing, because that's pretty diverse. So yeah, just a note to consider, giving examples of the sorts of things we might be sharing and why we might be sharing those things as well.
Yeah, so as much as possible, trying to be very transparent around the types of information and who we're sharing with, and trying to, as much as possible, bring the victim into the safety planning process, of course, which is, of course, our next steps. Thank you so much for your time tonight, Jennifer and Vida. I'm pleased that we actually can continue this conversation. Our Family Violence Echo kicks off next week, and I think you'll both be our subject matter experts for the session. So do register and come on board. We'll be sharing case studies and thinking about how we put a lot of these principles into practice in our clinic setting. So do please jump on board. I think in the chat, Jade has shared those registration links and all those links to all of our other series educational offerings. The video will be available afterwards for catch up, and please do share with your colleagues and networks. I wish you all a good night.